appropriate to say thank you to Susan and the whole team and Jerry and Diane for what they put together and their willingness to come out and share this with us. Thank you very much.
Thank you. Thank you. Thank you. Thank you very much. Can you hear me okay? Yeah. You're all familiar faces this week. So just to remind you, my name is Sue Daniels. I work on the Palliative team, which includes Hospice at Middlesex Health. Today I'm talking about something that's really near and dear to my heart. I used to be the nurse manager on a dementia special care unit in long-term care. And it was the toughest job I've ever had. But I think that there is so much that we have to learn about dementia. It's not a very visible problem in our society, but it's a very prevalent problem in our society. According to the Alzheimer's Association, currently there are about 6.5 million people in the United States living with dementia. That number is expected to go to 13 million by 2050. So why is dementia such an issue for in our country? Well, part of it is a testament to the fact that we keep people alive a lot longer than we used to. So the kind of things that used to end people's lives when they were in their 60s and 70s, they're now able to get under control so that people are living to their 80s, their 90s, over 100. It's not unusual on the comfort care unit where I spend a lot of my time in the hospital to have all of the residents up there, or all the patients up there, be in their 90s or above. And so when we get somebody who's in their 70s or 80s, we say, oh, this one's young, because we're doing a lot more in the community to keep people well. But because of that, then the dementia that probably would have reared its head at some point in people's lives didn't get the chance to. But now that people are staying alive longer, dementia is going to be a bigger problem. So our objectives today are to understand dementia and delirium and identify distinguish between the two of those things. Also identify the signs that somebody who has dementia, that their dementia is progressing. Because the diseases that cause dementia are terminal diseases. And so we're going to talk a little bit about that. A lot of people don't think about dementia as being a terminal condition, but it really is. And then just again to talk to you about to know who to call for help. I am going to just insert a little commercial for Middlesex Health right now, because as I've mentioned previously, I'm really proud of my organization for valuing this palliative program enough to have people there who can have a conversation with you free of charge. We don't get your insurance information or anything like that, but they know that this is really important to people, and that sometimes people who are suffering from any kind of serious illness, whether it's dementia, end-stage organ disease like COPD or CHF, or any of those illnesses, or cancer, or any of those illnesses, sometimes you need somebody to talk to. And we spend time just talking about how this illness is really impacting your life and where it's going from here. A lot of times you don't get a chance to really ask those kind of questions with your doctor because you're busy talking about other things when you're in the doctor's office. But just to kind of put things into perspective for you so that you know where you're going, you know when you might need more services, you know who to ask if there are services available that can help you. Okay, and most of the time you're going to be talking to me, so hopefully you feel comfortable doing that now. And if you haven't gotten my card in past weeks, please take my card, or you can take one to pass on to somebody else who you think might need this service. Okay. So let's talk about what is dementia. Dementia is not a disease in and of itself, and a lot of people don't realize that. Dementia is a condition, or it's a group of signs and symptoms that make up like a syndrome. But there are a lot of different diseases that cause dementia. So when people say that they have a loved one who has dementia, you don't really know too much about that person. It's very nonspecific. So like think about the term fever. If somebody came up to you and says, oh, I have a fever, you really don't know anything else about, what's causing that fever. Do they have the flu, a virus? Do they have an infection? Are they dehydrated? You know, it could be due to a whole bunch of different things. So if somebody tells you that you have dementia, or that somebody that they know has dementia, you don't know anything else about that person, you know, if you don't know what else is going on with them. I mention that because a lot of times when something that I think troubles caregivers is that there's a lot of other experts out there in the community who will say, oh, you know what, my sister-in-law had dementia and you should do this or you should do that. So, you know, I would take it with a grain of salt and be gracious if somebody wants to offer their advice, but know that there's not like a one-size-fits-all path of this condition, and nor is there one-size-fits-all solutions to the problems that come with dementia. There are many different diseases that cause dementia. The most common one is Alzheimer's dementia. I feel like the Alzheimer's dementia is a less diagnosed nowadays because they know more about the other dementias. When I worked on the dementia special care unit, it was back in 99, 2000. Anybody who had a diagnosis that they couldn't find something else to apply, you know, a different kind of dementia, it wasn't an obvious kind of dementia, they would say they have Alzheimer's type dementia. But back in those days, the only way that you could diagnose Alzheimer's dementia was on autopsy. So it was a guess. It was a best guess based on, you know, the fact that they didn't really fit the profile for any of the other diseases that cause dementia. So then there's vascular dementia, is the second most common type of dementia. And vascular dementia is, you know, when you have problems in the microcirculation of the brain that shuts off the supply to cells, and you get some deterioration of cells in the brain from that. There's Lewy body dementia, which is a protein that deposits in different tissues in the body, including the brain. Frontotemporal dementia, those are probably the most common ones. But there's also a lot of diseases that have dementia as a feature in the later stages of dementia. So like Huntington's disease, Parkinson's disease. When I was in nursing school, they said dementia was not part of Parkinson's disease, but now they're keeping Parkinson's patients alive a lot longer. And so now we are seeing dementia with people with Parkinson's. Total brain injury, sometimes there's that late effect of dementia if somebody's had brain injuries. So that's, you know, how they're talking about how boxers or football players have late effects of head injuries that they suffered while they were practicing their sport, because this may take many, many years to show up. And then CVA, cerebrovascular accident, is another thing that we see a late effect. We see dementia late effects in that too. So dementia, again, not specific, depends on what the disease that's causing it, how it's going to show up, and it manifests by what part of the brain is affected. So this is not an anatomy and physiology course by any means, but I'm just going to give you kind of a quick and dirty idea of what I mean by that. Certain dementias affect certain parts of the brain primarily, like the frontotemporal dementia, or Pick's disease they used to call it, that affects like the frontal lobe and the parietal lobe. Other kinds of dementia might be more global, or might, you know, be patchy, affecting different areas of the brain. And your brain, I don't know if you know this, but your brain has a lot of different functions, and depending on what part of the brain is affected depends on how it's going to show up in your functioning. So if you have word finding difficulty, that might be like in the front part of the brain, or so the frontal part of the brain is responsible for like personality, decision making, movement, smell recognition, speech, coordinating speech. So sometimes when you know that somebody's been diagnosed with dementia and then you kind of look back on things, you can say, oh yeah, I did notice at one point that there was a change in, like, she could never come make a decision. She used to be such a decisive person, then all of a sudden, she was just like, I don't care, whatever you think, and that may have been already the dementia. A lot of times, people are well into a couple of years into their dementia before people really realize what was going on there. The parietal lobes, those are the yellow ones in this picture. They're responsible for object recognition, spatial relationships. So, sometimes people, if like with the frontoparietal dementia, they just tend to like walk right into people, like as if they're not even there, or walk into the walls, or kind of bounce off the walls as they're walking. Touch and pain perception. So when I was on the dementia special care unit, we had a handful of people who really hated their shower, and it was like a painful, and there was one fellow who was very articulate, and when we would put him in the shower, he would say, needles, needles, because that was the sensation. So we learned then that we needed to bathe him differently and try to avoid using the shower with him. The parietal lobe is also responsible for speech interpretation. And then the temporal lobe is responsible for short-term memory, developing short-term memories. So those folks who, get in an argument one night and then the next morning they forgot that they had that argument, that is maybe because their temporal lobe is affected. It's responsible for speech as well. There's a bunch of different areas in the brain that are responsible for speech, different aspects of speech. Communicating with another person is a really complex issue for the brain. The brain has to hear the information, interpret that information, process, the meaning of that information, come up with a response, articulate that response, and those are all different parts of the brain that do that. So anytime a certain part of the brain is affected that's, in that chain, then the person might have difficulty communicating. I've seen patients who cannot speak normally or have a normal conversation. They have what we call expressive aphasia, meaning that they can't talk normally. But then if you sing with them a song that they're familiar with, they can sing the whole song perfectly. And that's because the Broca's area is a different part of the brain that might not be affected by that. And then the temporal area is responsible for music and rhythm and also smell interpretation. The back of the brain, the occiput, is the part of the brain that's responsible for understanding visual input and understanding it. So if you've have a lesion back there, your eyes might be working perfectly well. You're seeing everything that I'm seeing now, but because your brain doesn't know what to do with that information, they're effectively blind. And then the cerebellum, at the base of the brain there, is responsible for balance and posture and equilibrium. And so sometimes people, if they have lesions at that part of the brain, will have what's called ataxia, where they can't walk straight, or they're tipping over, or you see them leaning in funny directions when they're trying to walk and things like that. And of course that's important to know that they have that, because there's going to be some safety issues with that. I'm going to talk for a minute about the differences between dementia and delirium. They're two different things. Dementia, of course, is a permanent and progressive illness. You see usually a more gradual, you might see a fluctuation in their function from day to day, depending on their energy, their rest, their hydration, and all that kind of thing. But in general, they're pretty much the same from day to day, with smaller declines in function. With delirium, that decline is sudden. However, the reason I'm telling you this is that delirium, which is a condition that's temporary and often treatable, if someone with dementia also has delirium, it's important for you, if you're the family caregiver or the person who really knows the patient with dementia the best, to communicate the baseline function of this patient to healthcare people. I have seen in some cases, people come in. So even if you have a mild dementia, it's going to be in your record that you have Lewy body dementia or Alzheimer's dementia or something like that. But you might be somebody who comes to church, engages in social activities, is able to walk a mile every night, all those kind of things, and now all of a sudden you're very combative or agitated, and you come in and your record says that you've got Lewy body dementia. The caregivers might assume that that's your baseline. Your combativeness is just your baseline. But so you as the family caregiver would need to communicate to this is not her baseline. She's usually she's only just been diagnosed with this dementia. She's very functional. She still goes to work. There are people who go to work who have dementia. And so, you need to be the one to communicate that this is different and we want you to look a little harder at what's going on here. Okay, so signs of dementia, what are the stages of dementia? This is not intended to be a really in-depth look at any of these things, but I want you to understand the stages of dementia so you understand the trajectory. I know that you've all been here before when you've seen those pictures of the different trajectories of dementia that relate to what level of function people are at. And you may remember that the people with dementia, this tends to be a very protracted illness for a lot of people. People can have it 12, 20 years. So by the time they're entering the very late stages of dementia, they usually have really poor functional abilities at that point. And their caregiver, if they're still living with their family caregiver, that person probably, her or his world has gotten smaller and smaller over time as this person's dementia has worsened. So, in very generally, I'm just going to talk about the stages of dementia and also how people's goals of care, if they're getting treatment for other things, may change depending on where they are in their dementia. In early stage dementia, people have word-finding difficulties, maybe forget names. If they're still working, their colleagues might notice that their work performance is, being affected. For some of these people, they're not even diagnosed yet. A lot of times, it's only in hindsight that you realize that the onset of dementia for somebody was a couple of years ago. Reading comprehension can be affected. I see a lot of people, when I was in home care, I used to see a lot of people who were in the habit of reading the newspaper every day. And so even though they really have progressed in their dementia, they sit down with that newspaper and open up the newspaper every morning. The difference is that if you ask them about what they just read, they can't really tell you, or they'll say, make a general comment like it's all bad or something like that. But that act of actually reading the newspaper every day is very calming for people when they have that as their normal habit. Losing things is a very common one, and losing their way after a while. People who are still driving, sometimes it takes them longer and longer to get home. Maybe you hear from the neighbors that they keep, driving around in circles, what's going on. And then planning and organizing is a problem. Another complaint that we hear a lot of times when people are in their very early stages of dementia, like a wife will say, he's always paid the bills, and all of a sudden his checkbook is a mess. And, sometimes that's how dementia presents for some people. Then the middle stage of dementia, people have difficulty with self-expression, expressing themselves, articulating what they want to say. There's probably some noticeable memory loss at that point. They can't remember. You need to keep repeating directions, or maybe giving directions one step at a time to them. They might start to get confused about the time, the date, the season, being dressed inappropriately for the season, that kind of thing. We see more wandering in the middle stages of dementia, and we see personality and behavior changes when they get to the middle stages. In late stage dementia, that's when people really need around-the-clock supervision. There's a loss of awareness of their surroundings. They may start to have more difficulty with physical functions. A lot of people think of dementia just being about the diseases that cause dementia just affecting the brain, but the brain governs the whole body. So you're going to start to see physical changes in the patient too. So they might have difficulty walking. They might not be able to sit up, support their trunk when they're sitting without support. And then in the late stages, we also start to see issues with swallowing. They tend to be much more sedentary at that point because they're not walking and things like that. And so that also makes them very vulnerable to infections, particularly pneumonia and urinary tract infections. Pneumonia happens because in this population, because they are so sedentary, and this is true of anybody who's sedentary. If you're not aerating your lungs to your bases, fluids can start to build up in there, and that's a good environment to start to foster bacteria building up as well. So with those folks who are more sedentary, and this is true of any of you, it's always good if you're laid low or you've just had surgery or something like that, to do that incentive spirometer that they give you in the hospital for surgery, to stand up, change your position, make sure you're getting air down to your base, and doing that cough and deep breathe, which you can just do with a pillow, to splint your belly or whatever, and breathe all the way down to the bases and cough a couple of times an hour, every hour, will keep you healthy. That's just a little side tip for you. And then behavioral changes that come with dementia. In the early part of it, again, think about people who maybe are not even diagnosed yet, but you might see that socially they seem to be changing. They're losing their filters, as the kids say, right? They're just saying out loud the things that are supposed to stay in their head. Maybe they're having more interpersonal conflicts, or they're just just don't have the social grace that they used to, and somebody invites them to go, come for dinner, and they say, I don't want to go to your house. Oh, you're a terrible cook, or something like that. Those kind of things where they just don't edit themselves before they say what they're thinking. You might see more interpersonal conflicts, the personality changes, loss of impulse control, and if the patient is diagnosed with dementia at this time, it's hard to do, but it might be a good time to talk about goals of care. Because the goals of care are looking ahead to, we know you've got an illness right now that eventually may take your life, if something else doesn't get you first. And so at what point would you want to stop trying to extend your life? That question that we always ask, what if your doctor had to make a decision for you right now? Would you rather that he do whatever he can to extend your life as long as possible, even if you might have more pain or discomfort? Or would you rather he focus on your symptoms, even if you might not live as long? That's kind of a non-threatening way for people to think about what their goals might be if they should get pneumonia, get a urinary tract infection. In hospice, if you're on a hospice program with dementia, we can keep you very comfortable at the end of life. Do you know that old saying, pneumonia is the old person's friend? That came from the idea that is a very manageable illness at the end of life. Nowadays, though, people come back into the hospital again and again and again with pneumonia, and it's not as much of a friend to them anymore because we keep pumping them full of antibiotics and fluids, and then they have fluid volume issues, and they start to get super infections from the antibiotics that they're taking. It's okay to let an infection run its natural course. And when I say that to people, sometimes they feel like that's barbaric when I suggest the next time he gets pneumonia, if you want, we can just keep him home and manage his symptoms. For some people, that's unthinkable because all we have to do is give them an antibiotic. But antibiotics are not the benign treatment that they are when you're getting them again and again and again. They do a lot of damage to the body. They, create an environment that breeds super infections that are really hard to knock out. And so it's not, and it might not be for you, but it's worth considering. And so if at this early stage of your dementia, you think ahead about that, I've told my children, if I'm not able to participate in the conversation about whether or not I want to keep going, then that's the time to let things take their natural course if I get ill. Likewise, we have lots of people who have dementia and then they get diagnosed with cancer or something like that. And the agony that people go through saying, well, it just doesn't seem right not to try to treat the cancer. But if you reframe it and say, you've already got a terminal illness, and it's okay if you let this thing take its natural course. Usually if they're symptomatic from their cancer and they decide not to treat, a lot of the times they're already hospice appropriate, or else we, let them know when they can come back to us, when they're ready for that. So it's not wrong to consider not treating either. In my opinion, that might be an opinion thing. In some cultures, it's very important that you take advantage of everything that's out there, but it's worth consideration. Then in the middle stages, I'm getting back to behavioral changes. In the middle stages, you'll see that people are more intolerant to change. We're talking about behavioral changes. They may resist having their activities of daily living. That's a term that you hear a lot if you're connected with healthcare. Activities of daily living are bathing, toileting, or using the bathroom, eating, dressing, all those things that the home health aide does with our patients to get them through the day. You might also hear the term IADLs, which is it intermediate activities of daily living? Now I don't remember. I have it written down somewhere. But that's like shopping, doing all the things to help run the household. So in the middle stages, people have more resistance to doing their activities of daily living, more difficulty getting it done. It kind of reminds me of when my kids were preteen, and you'd say, go brush your teeth, and they'd say, can't I even have a day off? But the things that they're really supposed to do all the time, and they're not paying attention to their own care. You might see more agitation and restlessness, wandering, rummaging is a big thing. So think about it yourself. Have you ever had that experience where you say, oh, I got to go get this thing, and then you walk into the next room and you forgot what that thing was that you wanted to get, right? Doesn't mean you have dementia. It just means that you have a lot going on up there. But what do? You start looking around, maybe you look in the cabinets, you're trying to jog your memory. So rummaging is part of that. They're trying to find some direction, and so sometimes they start to rummage, and it drives their loved ones crazy because they, make a mess, or, can get into trouble, turning a switch on that shouldn't be turned on, things like that. So again, safety issues with any of these behaviors. Time confusion, paranoia, and hallucination are all characteristics of middle stage dementia. In late stage dementia, sometimes people can have catastrophic reactions when they're unhappy that are out of proportion to whatever is happening. And that's where things can get very embarrassing if you're the family caregiver, or where you don't want to take people out anymore. You don't want to be in a restaurant and knock. The patient knocks over a glass of water, and all of a sudden there's a big uproar, and he's throwing a tantrum or something like that. And so, unfortunately, that's why we don't see dementia out there as much as it's out there, because a lot of times I always say people's worlds get very small. They're kind of restricted to home because they're afraid of having these catastrophic reactions. It's also not necessarily like the things that the patient with dementia used to enjoy, they may not enjoy anymore. When I was at the dementia special care unit, there was one group of patients who the program director would take out for outings to the mall or to a restaurant or whatever. They were higher functioning people who could actually enjoy that. But and it was like a cohort of them that all seemed to kind of go downhill at once. And it was always sad when she said, I don't think I'm going to be able to take Mary out anymore because it's no longer pleasurable for her to do that. So in some ways, I'm not saying that you should try to get somebody out with dementia if they're having, behavioral problems when they're going out, because it might just be too overwhelming for them. But that's where last week's discussion about caring for the caregiver and caring for yourself is going to be very important. Incontinence is a common sign in later stages of dementia. Sundowning, which is where people start to have behavioral issues after, at dusk or after dark. Sleeplessness or interrupted sleep. And of course, if you're the only caregiver taking care of this person, if you're the spouse or somebody who's living with this person, that can be a nightmare for you because you've been taking care of this person all day. sleep is your respite, and then the patient is up and down, or the person is up and down all night because they're having sleep difficulties. We see refusal to eat. Some of that is behavioral. Some of that may be already, those later stages where people are not able to coordinate swallowing anymore. So it's important to kind of figure out what the cause is there. And then, of course, people may have skin issues, and because of the incontinence and because they're more sedentary, and there's more of a susceptibility to infection then. So, so back to the goals of care conversations then. As I've mentioned in previous weeks, having these goals of care conversations, early and often should be the rule if you or someone you love has any kind of serious illness, because your goals of care will likely change over time. And especially with someone with dementia, when you have a good quality of life and you're still able, maybe you get diagnosed, you retire early, you're making the most of your life at that point, maybe then you would want to treat, anything else that might come along. But as it progresses, you might want to change your advance directive, rethink whether or not you even want to make repeated visits to the hospital. And at that point, you're going to call your palliative care specialist and say, here's what's going on. What do you think? Can you get in touch with the doctor for me? And we'll go from there. The other thing I can't stress enough is that when you are accompanying somebody with dementia to the doctor, to the emergency room, to any healthcare, in any healthcare situation, have the courage of your convictions. If they, you're the expert on that patient's baseline, so let them know what the baseline is, because whatever is bringing them to the doctor or to the emergency room is probably going to cause a little delirium on top of what they've already got. And so if the patient's goal of care is to get back to their baseline and not just let things run their natural course, you need to let the doctor know what the baseline is and not be afraid to speak up about it. There's a couple of tools that I want to talk to you about in terms of how we know what the trajectory is going to be with somebody's dementia. And one of them is the Palliative Performance Scale. It's so basically, if you were calling me on the telephone for a goals of care conversation, at some point we'd get to the point where I'll say, well, how are you doing getting around the house? Do you need a walker? Are you getting up and down out of the chair independently? Can you get out of the house? Is it hard for you to get in the car? Are you still driving? I'll ask all these questions to kind of get a feel for how mobile you are. And then I'll talk to you about the disease itself and what you're feeling from it. Some people have very serious illnesses and have learned to cope with it and their perception is that they don't really have anything that's affecting their life. Other people will give me a big long laundry list of the way that their illness is affecting them. And so I'll ask them, are you able to work still? Are you able to do housework? Are you able to do your normal hobbies? And get a feel for how active you are in that way. I'll find out if people are independent in their activities of daily living, so they'll go into the bathroom and feeding themselves and dressing and there's 7 of them. It's never good when you're given a talk on dementia and you can't remember. But I'll ask you those questions, then I'll ask you how your appetite is, and if you're losing weight, if you've lost weight unintentionally, and then I'll ask you about your, whether or not you're having hallucinations, if you're falling asleep when you don't intend to, like drowsing off during the day, if you're having any confusion. People are very, you can be falling asleep for other things too. So, people are very forthcoming about, what's going on with them, and it's great. We have a nice conversation, and then we get to the end, and I, figure out what percent, it's a chart that we use, and it tells, are they at 60% of what would be considered normal, or are they at 40%? The reason that we do that palliative performance scale is that anybody who's 50% or less, it's indicative that they have a high chance of mortality in the coming year. And so they might really be somebody who's, ready for hospice at that point. And then specifically for dementia, if I'm talking to somebody who's got dementia, we also do the FAST scale, which is the Functional Assessment Staging Test. And that's a scale that goes from 1 to 7, 1 being that people have no signs of dementia at all, and 7, and it's like 7A through E, 7 being that this person is probably within that 6-month or less period of time where they would be appropriate for hospice. So I ask, again, do you need help doing things like preparing food? Does somebody else do the driving for you? That kind of thing. Then what are you, do you need any help with your activities of daily living? Does anybody help you? Do you have to have help transferring and ambulating, or 2 more? Transferring, ambulating, washing up, bathing, grooming, dressing, and feeding. And then are you fully continent? Now, people tend to lose the ability to remain continent in a particular order. First the bladder goes, and then the bowel goes. If a patient says, well, they're continent, or if the person I'm talking to says they're continent of bladder but not of bowel, that may be an indication that there's something else going on that's not related to dementia, and that we would tell them to see the doctor about that. Verbal ability is a really good indicator. So are they, able to use, do they have a normal vocabulary? Do they have 6 words or fewer? Are they able to respond appropriately when they're spoken to? Ambulation is a big indicator. Are they able to ambulate on their own? Do they need help? Are they totally not walking at all? That central motor control, so are they able to sit up without, I'll say, if he were to sit at the edge of the bed, do you think he would be able to hold himself up, or would he slump over? Are you worried he'd fall off? And that's a good indicator that things are really progressing if they're really at that stage. And the ability to smile or, respond to somebody whom they love is a very late stage thing that we look at. So we ask those questions, and again, if they're in the 7 range, which is really about the verbal ability, the ambulation, and the central motor control, and the ability to smile, then that person might be ready for, within the range for hospice if that's aligned with their goals of care. I just want to give you a couple more tips about visiting the doctor, because, and this is actually, you don't have to have dementia to know these things, but I think it's important just to know from an operational standpoint how to make the most of your doctor's visits. I don't know if you know that it's very, very expensive to run a doctor's office, and the way our healthcare system works in this country, for the doctors to actually not just turn a profit, but stay in business, basically, they usually have to employ an office manager who runs a very tight ship to make sure that they're seeing enough patients to get through. So it's too bad that as healthcare consumers, we don't realize that there is some burden on us to get ourselves organized and know why we're going to the doctor. If you're going to the doctor, figuring that the doctor's going to ask all the right questions and dig all the information out that you need to, that's probably not the attitude to go in with it. When you go to the doctor, before you go, you want to know exactly what you're going to the doctor for, what questions you're going to have. It's very helpful if you write these questions down and understand that the doctor may have only 15 minutes or 30 minutes, booked for you. And so everything that the doctor's got to do has to be done in that span of time. It's helpful when you make your appointment to say, how much time are you booking for me? And the receptionist should be able to tell you if it's a 15-minute period, if it's a 30-minute period. The doctor tells them. If it's a physical, they might say 45 minutes. If it's you're coming in to have one thing looked at, maybe, you want to have your ears checked or something like that, that might just be 15 minutes. Know how much time the doctor has allotted for you and prioritize your questions. What's the most important thing that you have to ask first? The doctor is going to really, or advanced practice nurse or whatever, is going to really respect the fact that you respect their time and that you're not trying to take up more time than you need to. Again, if you're the family caregiver who's bringing somebody with dementia to the doctor, know what the patient's baseline is, know what the goals of care are. Again, the doctors are not really used to having that in-depth conversation, and especially with a disease like dementia, that can get very complicated. And so the kind of conversations that I have with people with dementia, I usually say, do you have about 20 minutes to talk to me? But sometimes it can go for an hour. And, you know, it feels good to talk about these things and make sure that, you know, you feel heard, you know, when I'm talking to people on the telephone like that. It's so funny because I'll introduce myself in the beginning, I'll tell them what I want, do you have about 20 minutes? And then we get to the end of the conversation, they say, what is your name again? Because, you know, they didn't realize that they were going to have this kind of an in-depth conversation, but they want to be able to call me back if, you know, if they need me to talk to the doctor for them on their behalf or whatever. And I'm taking notes. Sometimes I'll read the notes back to make sure that I got it right. And that goes in your chart. And we're on Epic here at Middlesex Health. Even in home care, we're on Epic now. And so all of that information goes into the chart. So any other doctor in the system who's on Epic can also get a hold of that information. So the communication is getting better and better all the time. That's all part of, the Affordable Care Act said that we have to try to get an electronic record that where your information is portable. And so that piece is getting better, but the flip side of it is there's a lot of information on any one person. So again, there's a little bit of a burden on you as the healthcare consumer or the family caregiver to make sure that you're prioritizing the information that you're giving people, that you're giving the doctor so that you get the answers that you want to get. If you get to the end of the visit and you don't have all those answers, you can ask for follow-up or say, is there somebody else I can talk to? You know, sometimes the best person to talk to in the doctor's office might be the nurse because they have a little extra time built in. Their time is not billable. So again, remember that there's an office manager who has to make this doctor's practice stay afloat, or they're all out of a job. And so, but the non-billable people like the nurses, sometimes you will have a little bit of success if you can say, can I talk to the nurse for Dr. Smith? And start there. Because the other thing that the nurses will do is they do a little problem solving. And they'll bring the nut of what they think is going on to the doctor, and the doctor might say, you know what, let's make a referral to the urologist on this one, or whatever. So taking care of people with a couple of other things about taking care of people who have dementia when you bring them to the doctors. If you need the doctor to see what the patient's really going through, schedule the appointment for the patient's worst time. You know their circadian rhythms, and like if they really fall apart at the end of the day, you might be tempted to schedule them first thing in the morning when they're fresh as a daisy, but then the doctor might not get the full picture. Or, if that's the case and you decide that you're going to schedule them in the morning, first thing in the morning, or that's the only time that you can get the appointment, let them know that this is the best and that it's, and what the whole range is of their behaviors. A little family dynamic thing that happens a lot of times with people with dementia, I think I might have mentioned this previously, is like sometimes there's the one child in the family who's taking care of mom or dad or both of them, and they keep telling their siblings who live out of state, how things are deteriorating, but the siblings from out of state come and visit, and mom or dad pulls himself together, they look great, and then they think that the sibling is the problem, and I have had that conversation as a case manager many times where I say, I know that sometimes he's really good, but then other times these are what I'm witnessing, and that's normal, and it's normal for people to pull it together. If they really need to get a good idea of what's going on, what I recommend to people sometimes is there any way that your sibling can come in and stay with them for the weekend? Because then they get the whole picture of what's going on over a 24-hour period or whatever. If you're looking for a good book to read on dementia, the 36-Hour Day is, I don't remember who wrote it now. The 36-Hour Day is something that I have on on Audible. the audiobook, and I listen to it again and again, like depending on what the problem is that somebody's going through. I go to different sections of the book to listen to it. But it's very readable. It's not. There's another one by the Mayo Clinic, and Middlesex is affiliated with the Mayo Clinic. It's much drier. It's more intended, I think, for like a healthcare professionals, but even as a healthcare professional, I zone out if I'm listening to that one. So 36-hour day is really lots of practical advice on how to take care of your patient with dementia. And there's a lot of books out there, but those are the ones that I would recommend. Any questions on anything we've talked about?
You may have answered this. What's the difference between dementia and Alzheimer's?
So Alzheimer's is the disease, and dementia is what is caused by Alzheimer's. So if you compare dementia to fever, like an analogy would be pneumonia is the disease which causes the fever, Alzheimer's the disease that causes the dementia. Somebody with dementia may have Alzheimer's, or they may have, one of a dozen other diseases that cause dementia. So the question was, what's the difference between Alzheimer's and dementia? A lot of times people, and again, the Alzheimer's dementia, I think they've gotten much more sophisticated about how to diagnose it. When I was early in my career, everybody had, anybody who had dementia was called Alzheimer's. When I was in the nursing home, there were people who, as their dementia progressed, clearly had like a frontotemporal dementia or something like that. They're not going to bring that patient back in to be diagnosed because there was no cure for any of them. And to put somebody through that diagnosis is really hard. That's another challenge with the diseases that cause dementia, is that you have to get people to sit still in an MRI or an EEG, and it's confusing. And if you can't explain to the patient, if the patient isn't able to process what's going on, it can be very disturbing for that patient. And so a lot of times we know that this patient has dementia. The doctors might suspect that they know what the diagnosis is, but if there's nothing that they can do to treat it, the patient's not going to get that definitive diagnosis.
Has there been an increase of younger people with dementia?
Has there been an increase in younger people with dementia?
I see that at the Mazzani, where I do.
Yeah, yeah. There are, I don't know the answer to that. I don't know if there's been an increase in them. I mean, we do see, I think a lot of times people who otherwise would not have gotten help are now getting connected, and so it's more visible in some ways. A lot of times there's some early onset dementias that are genetic, like early onset Alzheimer's disease. There's some dementias that are caused by like an infectious agent. Psittacosis, there are certain like bird diseases carried by birds and things like that. Lyme disease, we see a lot of people in this area who have, we're in the Nutmeg State, and we see a lot of people who have late effect of Lyme disease. They have dementia. So in that respect, I think you'll see a lot of younger people with that type of dementia because they're out and active, and Lyme disease can have a very insidious onset, and it's very hard to diagnose sometimes. My husband, when he had it the first time, had to get tested for it like 3 times before they said, oh, it is actually Lyme disease after all. And he had had it for 6 weeks at that point. So. Any?
Well, the financial aspect of it, a person in his late 50s or early 60s, which I've seen, and they're there 10 years, and the cost is phenomenal.
Yeah, it
It's
can.
like $14,000 a month.
Yeah, the comment was that the financial aspect is devastating for people when they're diagnosed that young. A lot of those people we see have go on Social Security, because they've spent down all their assets. And you don't go on Social Security unless you've spent all your assets. But you're right, that can be devastating. People quit their job young, and maybe have a young family. Yeah, that's tragic. Other questions? The Alzheimer's Association, if you go online, the local one is in Southington, and you can, actually put in, I believe that during the time of COVID, they were kind of put on hold for a while, or they may have done them via Zoom. But they're a tremendous resource, and your loved one doesn't have to have Alzheimer's disease to take advantage of their resources. And that's a great point, that if you are a caregiver of somebody who has dementia, I strongly urge you to get hooked up with a support group type thing. If your loved one is in the early stages, sometimes they do have support groups where the patient and the caregiver can actually go together. And sometimes people just it's for the more advanced diseases. Yeah. Other questions, concerns? The last point, I don't mean to keep harping on this, but it's so sad that people don't realize, that dementia is there is a terminal progression to dementia, and that at some point they would be eligible for hospice. We have many, many people in our service area who never get hooked up with hospice because they never have that conversation. They never realize, it's always a surprise to people, not always, but quite often it's a surprise to people when I'm having a conversation that they might be eligible for hospice. People don't associate hospice with dementia, but in some ways those people need it the most, because remember that hospice is about the family and the patient, and I think the thing that we do best for people who have dementia is provide respite. Diane can tell you about how our volunteers go out there and provide respite for their loved one. They develop a relationship with the patient so that the caregiver feels okay about leaving the house and going out and running errands, or just going down to the river and having an ice cream cone, or that whole aspect of taking care of yourself is so critical if you are a caregiver of someone who has dementia. Whether you're living with them or whether you're just, overseeing their care from a distance, it's a tremendous amount of your time and your resources. And, when we see a spouse who's taking care of her loved one or his loved one who has dementia, it's almost like their life is ending prematurely too, because they're disconnecting from the rest of the world. And whatever we can do to help them reconnect, because what's really tragic, and with our bereavement folks, a lot of times we see people with very complicated grief after they lose their loved one because they've been caring for this person for 12 or 20 years, and that's become their identity, and they have no friends. They have been out of the workforce if they're young enough to still, be working. They don't have a social life anymore, and now they don't have the thing that was occupying all of their time. So again, we can really help you with that. If you know somebody, and I bet everybody knows someone who may be able to benefit from this, take a couple of my cards, say, I think you should call this person, and I'll be glad to talk to whoever you send my way.
At what point does hospice care at home change into hospice care at the hospital?
Hopefully never. So the question is, at what point does hospice care at home change to hospice care in the hospital? We have that comfort care unit up on South 7, which is where the nurses are specially trained to take care of hospice patients if they're sent there. So what under the Medicare hospice benefit, the intention of having an inpatient unit is to manage symptoms that can't be managed in the home. We're really good at Middlesex Health with managing people's symptoms in the home so that they don't have to come into the hospital. Some people still, so things have changed over the years. Remember that the hospice started out as an all-volunteer organization, then Medicare got involved in 1982 and started putting some regulations on it, and those regulations have gotten stricter and stricter over time. But the idea that the general inpatient setting is intended to be just to manage symptoms that can't be managed at home, I think that's really true to the core belief of hospice, that it's to try to help people die at home. Sometimes, a lot of times, we get people referred to hospice way late in their disease process, where they only have hours to days to live. And a lot of times those are the people that you see up on South 7 too. Some of them don't even make it to the point where we would sign them on, because if somebody is in the last hours of life, the last thing they want to do is start filling out a lot of documents and learning the difference between Medicare Part A and the Medicare hospice benefit and things like that. That's why we're coming out into the community and trying to get people to understand that it's a 6-month program at least, as long as somebody's within that 6-month window of probably being, at the end of life, they can be on that hospice benefit. And that the goal is really to try to get you home or keep you home, and support the patient, the family to take care of you there, whether home is your own home or a nursing home or an assisted living. Okay.
What's the percentage of male versus female that get dementia?
So what's the percentage? I think it depends on the diagnosis. In general, women live longer than men still. The life expectancy for women is a little longer, so I would say probably more female than men. I don't have numbers for you. But it also depends on the diagnosis. Like I think Lewy body dementia is more common in men. I want to say frontotemporal dementia, more common in men too. And a lot of it too, there might be a lot of different factors in what causes the dementia. There is some suspicion that there are environmental aspects to it. So, if people had exposure to certain chemicals and things like that, and a lot of times that would be men who, had that exposure. But I couldn't tell you for sure, what the overall percentages, the breakdown is. Some dementias are related to, are genetically related, and other dementias are not. So, if you've got it in your family, it's important to let your doctor know. The more you can tell your doctor about what type of dementia it is, the better they can tell you whether or not you're personally at risk or not. There is something that happens to all of us as we get older, where information just starts sifting out, and you might have some word finding difficulties or recollection and of certain ideas or things, or somebody in your family will say, "I told you that," and you'll be like, "I don't remember that conversation." But that doesn't necessarily mean that you have dementia. It might just mean that you're busy or you have a lot going on. There's a whole new category called MCI, which is mild cognitive impairment, which is, some people call it pre-dementia, but it doesn't necessarily mean that you're going to get dementia either. So I think pre-dementia is a little bit of a misnomer. But there's a lot of people, just because, you've lived a long time and things start wearing out, and, you not using a certain part of your brain, you start losing that ability, or you start to get more, your senses start to get more dulled, and that can contribute to cognitive impairment. And so, if you're listening to this and you're thinking, "Oh, I have that." When I was in nursing school, I had everything. I always went home and I said, "I think I have diabetes. I think I have," because anything's going to resonate with you. But it doesn't necessarily mean, but you should go to your doctor, once a year and get a physical and let them know if you have any concerns. They'll, they'll do that Montreal cognitive assessment test, the one I'm talking about, MOCA. What's that? You have to draw a clock. Yeah. So the president had to take it a couple of years ago. And it was in the news and everything. So then my mother's like, "Well, what is that test?" And so I said, I just took it myself because we started using it in home care. And she said, "Oh, can you do it on me?" And I was like, "Okay." And then after I said yes, I was like, what if I find out something I don't want to find out? But I did the test with her, and she did very well. And she said, "Am I a very stable genius?" And I said, "Well, it doesn't really test that, Mom." But it's just, somebody has to administer it. It's not supposed to be me, like, it's supposed to be somebody who's trained to do it. You have to draw a clock, you have to count backwards by sevens. So then she went to get her physical again this year, and she goes, oh, the doctor did that test with me. She says, I tried not to cheat. I said, Mom, the fact that you remembered that you took that test before, I think that bodes pretty well for you. Any other questions? Yep.
I'm asking, is there
Sure.
anything that people that helps be preventative from dementia coming on? Or?
That's an excellent question. Is there anything that can prevent the onset of dementia? And of course, because there's so many different diseases that can cause dementia, there's nothing that you can do to prevent everything. But in general, alcoholic beverages in moderation, good diet, exercise, all the things your doctor is going to tell you at your physical, those are all very important. Some studies seem to indicate that like doing a crossword puzzle like keeping your brain sharp, doing a crossword puzzle every day, doing the Wordle. Does everybody do the Wordle? The Worldle, the Quartle, we do them all, the Nerdle, all those, little games, on a regular basis can sharpen the saw. And part of it, I think, is just staying, aware of current events and things like that. Part of it is that, if your baseline is higher, you have longer to lose before you're functionally impaired in some ways. And so I think that may be part of, why they suggest to do these things to try to keep yourself sharp, keep your mind sharp. A couple of years ago, they realized that science has a replication problem, meaning that a lot of these studies that they do can't be replicated, and so it may not be good science, but it doesn't hurt to do your crossword puzzle every day or anything like, if it's not hurting anybody and, it's keeping, or, reading the newspaper is keeping you involved and not like giving you an ulcer or anything like that, then by all means, it seems like a good idea. Okay, very good. Well, thank you all for coming. I really appreciated getting to know you over these. Yep. Diane has a survey for you. So if we're supposed to make sure that we're having some kind of effect on people. And my cards are back there. So please don't hesitate to take more than one if you know of other people who might be able to benefit from giving me a call. I get lots of cold calls. It's not going to be unusual to hear from somebody out of the blue. Okay. Does anybody want any cards now?